Pisotriquetral joint injury. Anatomy. Pisotriquetral or PT joint is related to the pisiform where it lies within the flexor carpi ulnaris tendon. The pisiform is responsible for holding the triquetrum in position and prevents its subluxation regardless of the pressure put on it. It functions as a fulcrum while reducing strong forearm forces to the hand. Pathology. Pisotriquetral joint injury will present itself as PT tenderness, PT arthritis, post-traumatic arthritis, osteoarthritis, tendinopathy, and in some specific cases, paresthesia. Signs and symptoms / mechanism of injury. The main mechanism of injury is hyperextension of the hand as well as foosh or falling on outstretched hand. Those that have PT joint injuries have pain / tenderness on the palmar and ulnar aspects of the wrists around the pisiform bone. There may also be ulnar nerve symptoms as numbness and tingling in the ring finger and little finger may occur. Special tests. There is mainly one special test, the pisiform shear test, which is seen in this picture. You palpate that area of the joint and you go in a circular motion to see if there is more tenderness. There can also be SCU tenderness, triangular fibrocartilage complex or TFCC tenderness, wrist range of motion, and neurovascular exam. Predisposing factors. Unless you have a prior injury with this joint, there are no predisposing factors of PT joint injuries. Management and treatment. Treatment of PT joint injuries include local injections of steroids into the joint along with non-steroidal anti-inflammatory drugs, protective splinting, and pisiform excision if these conservative methods do not successfully terminate the pain. Differential diagnosis / referral / immobilization. Refer to an orthopedic specialist to discuss further diagnostic investigations of the PT joint as well as different options for management of the injury. In certain cases, immobilizing the area with a splint will help relieve pain in the joint. Osteoarthritis of the pisotriquetral joint must be differentiated from the extensor carpi ulnaris tendinitis, TFCC disorders, lunotriquetral disorders, and flexor carpi ulnaris tendinitis. The best radiographic view to evaluate the PT joint is a supinated oblique view. This view is obtained by having the patient position both hands palm up on the radiographic plate as though he were holding a large bowl. Prevention. You could attempt to pad the PT joint area, but there's not much else that you can do to prevent the injury. Avoiding falling on outstretched hand motions would be beneficial, but that is something that cannot be controlled in the athletic setting. Mulligan. PT joint injuries have no mulligan techniques, but a possible nerve glide to relieve pain. This is my PICOT analysis. Population. 20 wrists of 10 cadavers with an age ranging from 65 to 94 years. Intervention. 10 wrists were grossly dissected and 10 wrists were sagittally sectioned to analyze for type and grade of osteoarthritis. Comparison. If radiographs were accurate enough to determine types and grades of PT osteoarthritis and signs of anesthetopathy of the flexor carpi ulnaris. Outcome. Radiology, 2 out of 20 showed no osteoarthritis, 5 showed severe changes, and 1 showed the injury of the flexor carpi ulnaris. Microscopy. All showed some degree of osteoarthritis, of which 5 showed severe changes, 7 showed the signs of the flexor carpi ulnaris injury. Pisotriquetral osteoarthritis had a higher prevalence in the older donor population and would be the cause of ulnar side wrist pain, and there was no time needed for this research. These are my references.